Good afternoon, everyone. Welcome to Yashoda Hospitals webinar series. I am Dr. Amarnath, AVP Yashoda Hospitals. Today topic we presenting subtle signs of sepsis, nurses' key roles, and interventions in management. The global burden of sepsis is difficult to ascertain. Although recent WHO scientific publications estimated that there are 40 million cases and 11 million septic-related deaths worldwide, which is approximately 20% of all global deaths. So today we taken this topic. It is very essential topic for healthcare, tertiary healthcare especially, because sepsis is one of the diagnoses where financial burden is too high for healthcare providers as well as for the patient. So keeping in mind that how it helps nursing care in bringing out the clinical outcome better way in septic cases. So today we covering the types, signs, symptoms, and sepsis management, how nursing care help in sepsis management and better clinical outcome. I would like to introduce our expert panelists today. Due to expert panelist Dr. Yashoda, he is a senior consultant intensivist, Yashoda Hospital, Secunderabad. He is having vast experience, more than 2 decades in critical care, and he is handling a lot of septic cases. And today he is with us to overview around like how nursing care and what is sepsis, how to prevent and how to manage the topic. Thank you, sir, for today accepting our invitation. Even though your busy schedule, you are here today. I invite today's speaker, Ms. Gayatri, AGM Nursing from Yashoda Hospital, Somajiguda. Ms. Gayatri, please start the webinar. So after finishing your webinar, we'll go with our Dr. Yashoda's overview on the today's topic. After that, we'll take the questions. Please start the Gayatri, the today's topic.
Hello, everyone. It's honor and pleasure to be here. Thank you for joining us as we bring awareness on sepsis. Sepsis, more than 50% of patients in Indian ICUs meet sepsis criteria on any given day with high rates of antimicrobial resistance and mortality. When you ask to people, what do you mean by cardiac arrest, or what do you mean by heart attack? What do you mean by shock, or what do you mean by stroke? People are aware and people talk about it. But coming to sepsis, it is needed to have more awareness as nurses are being the front line in the healthcare of hospitalized patient. Early identification and treatment are cornerstone in the sepsis management. As with many medical advances and changes to best practices, it is essential that nurses stay well informed on the recent guidelines and recommendations in dealing with the sepsis patient. So in this webinar, we'll deal in detail about the sepsis. Let me share my screen. Let us talk about what is sepsis, what causes sepsis, what are the types of sepsis, and how do you calculate mean arterial pressure, and what is a nurse's intervention, which is the main topic of this webinar in the sepsis management. So what is sepsis? Sepsis is body's extreme reaction response to an infection. Sepsis happens when an infection you already have and our host response is giving extreme chain reaction throughout the body. So again, we come across many infections like UTIs or cold, cough, but doesn't mean that our organs are going to shut down. We are able to function better. When our body isn't able to do this, we have systematic effect on it, and it is called sepsis. So what causes sepsis? The main reasons might be infection from bacteria, virus, or fungi. So this sepsis can transform from one vital organ to the other vital organ in the body. For example, if the patient is having any existing pneumonia or any infection to the kidneys, bladder, or any other part of the urinary system, or any innate infection in the digestive tract, or patient is having any bacteremia, and any indwelling catheters are present to the patient or recently operated, or the patient might have met with any wounds or burns, this may cause infections and may lead to sepsis. So there are Types of sepsis. We have classified sepsis into 3 types. First is systematic inflammatory response syndrome. Next is severe sepsis, and the other one is septic shock. These types. One second. So there are 3 types of sepsis. First one is systematic inflammatory response syndrome. The next one is severe sepsis, and the other one is septic shock. So systematic inflammatory response syndrome, which is called SIRS, immediate to an infection, our body responds in a way that our temperature gets increased to 100.4, heart rate gets increased to more than 90 beats per minute, respiratory rate as well is increased, and there will be differential WBC of increased 12,000, or that there also might be decreased WBC to 4,000. So immediately after our infection, our host shows all these reactions. Increased, all the vital parameters will be increased or altered. So when this sepsis or the source of infection is not recognized, it may progress into severe sepsis. In severe sepsis, what happens is there is disturbance in finely tuned immunological response. As a result, there will be monocyte reactions, and this disrupts our cellular function. As there is reduced cellular function, the oxygen carrying capacity of the cells reduces, and all the vital organs in the body gets lesser oxygen. So as a result, our body goes into anaerobic metabolism, which leads to increased production of lactic acid. Always increased production of lactic acid leads to increased serum lactic acid levels, and that leads to lactic acidosis. So I hope you all are clear, or let me repeat. When there is sepsis, when the source of sepsis is not treated or not recognized well, it may lead to severe sepsis. In the severe sepsis, our cellular dysfunction happens as a result of immunological response. During cellular dysfunction, the oxygen carrying capacity of the cells comes down and anaerobic metabolism happens. During this anaerobic metabolism, there will be lactic acid production, and because of this lactic acid production, there leads to lactic acidosis. Because of lactic acidosis, metabolism alters and respiratory acidosis also may happen. And this have effect on all the vital organs of the body. So there also might be decreased urination, which is again symptom that our kidneys are being affected, and changes in mental ability happens. Along with this, there also might be patches on discoloration on the skin, and platelet counts comes down. Patient will also have respiratory acidosis. Because of this, patient might have difficulty breathing, abnormal heart rate or the heart functions, chills due to low body temperature. Patient might develop unconscious and extreme weakness. There also might be bluish discoloration of lips, fingers, or toes. Once severe sepsis is not treated or the source of infection is not identified well, it may lead to the final stage, that is septic shock, which leads to 50% of mortality for the patients. In septic shock, patient will have hypotension and thrombocytopenia happens. Urine output is reduced to less than 0.5 ml per kg, in which here we have to more concentrate on the serum lactate levels in the body. we have to check serum lactate levels every 2 to 4 hourly. The normal serum lactate level in the body is 0.5 to 2.2 millimoles per liter. And there also will be a drop in mean arterial pressure. This drop in the mean arterial pressure is mainly because of arterial vasodilation. So let us see how do you calculate mean arterial pressure. So mean arterial pressure to calculate is you have to have systolic blood pressure plus 2 into diastolic blood pressure by 3. So SBP is nothing but systolic blood pressure and DBP is nothing but diastolic blood pressure. Here, let us take an example of patient who is having 90 by 40 mmHg of blood pressure. For this, let us take 90 systolic blood pressure and 40 diastolic blood pressure. When you calculate, here the result comes 57 mmHg, as you all can see on the screen. So the most important aspect is nursing intervention. This is 1 hour bundle. Here it mentions that always consider sepsis as a medical emergency. As per CDC, sepsis is always defined as a medical emergency and consider it as the same. So for being a medical emergency, the time 0 gets calculated within 1 hour of receiving patient to the hospital. You have to measure lactate levels of the patient. Remember, the lactate, it should be always calculated you have to check lactate level every 2 to 4 hourly. If the initial lactate is elevated to more than 2 millimoles per liter, before you administer any antibiotic, blood culture should be taken. And the third point will be administer broad spectrum antibiotic because they act on both gram-positive and the gram-negative bacteria. So in addition to this, begin rapid administration of crystalloids. The crystalloids mainly are normal saline, RL, 5% dextrose. Why we choose crystalloids is that they always help you to reduce, to increase the to correct the hypotension and also to maintain the hydration status of the patient. The next step will be apply vasopressors if hypotension is more for the patient, and you always should focus on the mean arterial pressure has to be maintained more or equal to 65 mmHg. So these 5 key components are very much important in the nursing management of the patient with sepsis. Let me repeat again. You have to calculate, measure the lactate levels. If the patient is having initial lactate of more than 2 millimoles per liter, and always obtain blood cultures before administering antibiotics to the patient. Choose broad spectrum antibiotics, and rapid administration of crystalloids are very much important to maintain the hemodynamic status of the patient, and also vasopressors for the hypotensive to maintain hypotension. The next important thing in the nursing intervention is that identify warning signs of the patient. As we have already spoke that there will be vital organ involvement and the systemic response, we have to always make sure that intake output of the patient is calculated and hemodynamic status of the patient is checked every now and then. Source of infection should be identified. This can be identified whether patient is having indwelling catheters with any lines, or they are being the source of infection, patient had met with any accidents, or there are any open wounds. If so, check for the drains and the secretions, any smell, consistency, and the color of these secretions has to be checked. Follow aseptic precautions, which is very much important when you get in contact with the patient, when you touch the patient or follow any nursing interventions to the patient. Monitor vital signs. As we stated before, the major key point is monitor vital signs, and GRBS monitoring is very much important. Because of this immune reactions, there is a chance of release of excess glucose into the bloodstream, because of which patients usually who do not have diabetes also will show up with increased glucose levels. So for this, you have to check GRBS of the patient. If patient is having more GRBS, more than 180 or less than 180, please kindly inform to your intensivist. You have to calculate, monitor always central venous pressure and mean arterial pressure. You have to reassess the patient for the hemodynamic status very often. and strict intake and output chart has to be maintained. This intake and output, as you are infusing 300 ml per kg to the body, the output is also important. When the output is less, it is alarming again that kidneys are being affected. So always monitor strict intake and output chart. Nutrition plays an important role as protein breakdown happens and muscle wasting happens for the patients who are on sepsis. So nutrition also equally plays an important role. Make sure that patient is having 0.8 gram per kg of protein, which is very much important if patient is having any wounds to heal. If patient is having any open wounds, make sure that wounds are being assessed for the signs and symptoms of infection. Any indwelling catheters or lines are present, proper catheter care and bundles to be followed. Hope you all have got awareness on the sepsis. So let me ask few questions which we have dealt or discussed before. The first question is, medical management of septic shock includes what all except? Among the 4 options, what do you do for the medical management of sepsis except one? First one is administration of colloids, administration of crystalloids, aggressive fluid resuscitation, aggressive nutritional supplementation. What do you do? Please give your answer in the comment section below. Okay. The answer is A. You have to go for administration of crystalloids. You have to give aggressive fluid resuscitation, and you also have to have aggressive nutritional supplementation. As I said, muscle wasting happens during sepsis. Administration of, other than administration of colloids, you'll go for all other 3, B, C, D. The next question, the main goal of treating septic shock is, why do you have to treat the septic shock? And how do you treat? The first option is preserving the myocardium, restoring the adequate fluid status, identification and elimination of the cause of infection, identification and elimination of the cause of allergy. What is the main goal of treating septic shock? What is the first and foremost step you do while treating a septic shock? Yes, you are right. As many of you have answered, identification and elimination of the cause of infection is very much important to identify the root and to take it out. So identification and elimination of cause of infection is the right answer. So the next and the last question, patients receiving fluid replacement therapy should be frequently monitored for what? First one, adequate urine output, changes in mental status, vital sign stability, all of the above. So all of the above is the answer. When you are giving fluid replacement therapy to the patient, make sure patient is having urine output and changes in mental status, which again denominates that patient is maintaining proper hemodynamic status, and vital sign stability, as we already have spoke that it is the principal factor while dealing with sepsis. So all these 3 you have to look for. Thank you.
Thank you, Gayatri. You made this septic shock and sepsis, what is the stages and prevention management, very simple way. Hope our audience is following, and we try to keep it very crisp and short presentation so that online everybody here. Any doubts related to the today's topic, you can put us questions within 24 hours. We reply you back. And I would like to request our our guest today, for our expert panelist for today's topic, Dr. Shashidhar, to just overview on today's topics.
Very good afternoon. Thank you, Dr. Amar.
Yes, sir.
Thank you for the opportunity.
Yes, sir.
Sepsis is very important in day out of our management. So, and we need full nursing support for the management of a septic patient. Majority of septic patients will be in the ICU and either in step down or HDU units. So, first of all, how to identify a patient with sepsis? That is the most important thing. So, to identify in the ward side, maybe you can use mu score or QSOFA. QSOFA, which was there previously, it is very easy to calculate and use. It contains only 3 components. One is your height. You can remember it with a mnemonic of HAT. H is hypotension, that is a systolic BP less than 100. A is altered mental status, someone whose GCS is less than 15, that you can take. And T is tachypnea. Tachypnea is respiratory rate more than 22. So any of the 2 are there, then that patient is considered as sepsis. So maybe the sensitivity is very high. You may get other patients who are not septic. Still, you can identify major cases with this QSOFA scoring. So once you identify, you look for the source of sepsis. Someone in the ward or emergency, if someone is having any of these 3 things like hypotension, altered mental status with high respiratory rate, then you immediately triage them and identify whether they have any source of infection. Source of infection, you have to do the top to bottom examination. So strip the patient and examine from the top to bottom, identify for a source of infection. And anyway, vitals will be calculated for the admitted patient. So temperature you have to see. As Gayatri told, there are SURS response, that is temperature, respiratory rate again, and it won't contain this thing. TLC will be there, TLC, and BP won't be there in the SURS response, but that also you can take. So looking at these features, you identify the patients and then start the therapy. So first thing, when you identify a septic patient, so see the volume status. If the patient hemodynamics are okay, see the volume status and administer the fluid. If the patient is having hypotension, then immediately start the fluids. And as she described, it is 30 ml per kg crystalloids. Crystalloids in that you can choose normal saline or balanced crystalloids like plasmolite or ringer lactate, any of them. Though the patient's lactate is elevated, you can still use the ringer lactate, because if patient's liver is working, the lactate will get metabolized in the body and it will get converted into the bicarb. So taking a blood gas analysis with lactate to measure the lactate, that is the dictum. And anyway, she told the bundle, first hour bundle, 3 hour bundle, 6 hour bundle. So in the first hour bundle, you have to take see the lactate level and give the fluids. While administering the fluid, you start the vasopressors. The choice of agent is noradrenaline. Don't wait for your doctor to put a central line to start noradrenaline. You can start noradrenaline. It is the drug of choice, vasopressor. You can start through the peripheral line. So start the noradrenaline through a peripheral line and secure a large bore IV cannula, preferably 18 gauge or 16 gauge, and give the fluids through that line. As per the surviving sepsis guidelines, the amount of fluid, 30 ml per kg, has to be given in less than 3 hours, but try to give as early as possible. With that fluid, most probably your patient will be better. And after that, if required, you have to manage with the vasopressor support. And noradrenaline, till it reaches to a level of 1 microgram per kg, you can administer through the peripheral line. Then you take the help of the doctor and try to insert a central line. So once central line is inserted, again you have to meticulously maintain the sterility of the line. Then antibiotics. Antibiotics, usually doctors will prescribe the antibiotic and they will leave. So your job is to make sure that you take the blood cultures before administering the antibiotic. And there are antibiotics, different classes of antibiotics. Some has to be given over infusion, some has to be given as a bolus. So usually in our practice, almost all antibiotics we will try to give in a 100 ml NS. We will add to the NS and we will give it over 1 hour. So there are time-dependent antibiotics and concentration-dependent antibiotic. You discuss with the doctor, and if it is time-dependent antibiotic, try to give them as a prolonged infusion so that the efficacy of the drug will be more. and their concentration levels in the plasma will be at the more than MIC values for longer period, so that the drug effectiveness will be more. And time-dependent antibiotic, usually the drugs like aminoglycosides, which can be given as a bolus over 1 hour. Vancomycin, aminoglycosides, all those agents. So after administering the antibiotics, search for the source. Both things should go hand in hand. Resuscitation and investigation, both should go hand in hand. So investigation, after discussing with the doctor, relevant investigations like basic metabolic panel, cultures, and whatever the source you are suspecting. If your patient has come with symptoms of cough, breathing difficulty, and you are suspecting pneumonia, then X-ray or CT scan depending on the requirement and stability of the patient. And if he has come with some gastroenteritis features like loose stools, vomitings, then you do the ultrasound abdomen, or you can suspect the urinary tract infection which has led to the other organ dysfunction. So ask for CUE and look into the CUE, whether pus cells are there or not, and send the urine culture. And if someone comes with the trauma, wound infection, so then look for the source and involve the surgeon as early as possible. And you are the key people. Nursing team is a very crucial team in the management of septic patient, because sometimes source of sepsis will be identified by you people, and someone coming with tropical fevers, especially scrub, lepto, those patients from the top to bottom, we have to see for the rash or eschar, especially in the axilla, gluteal area, inguinal area. So you find for the eschar and identify, and then we can narrow down to the diagnosis. So that is the importance of identification of the source. Once we identify the source, then appropriate antibiotic, whatever antibiotic we thought of. Usually we start with broad spectrum antibiotics to cover all the organisms and pertaining to the organ. And along with that, you try to control the source. Suppose if it is a surgical cause, then abscess is there, perineal abscess or cholecystitis or liver abscess. Now maybe some wound infection, as we thought of, post-surgical case coming with wound infection, cerebral abscess. So there you try to do the source control, involve the surgeon and try to do the source control as early as possible. And this comes in the first important management of the sepsis. And once while doing other things, what we do for all ICU patients, like fast hug BID, that has to be followed meticulously. Gayatri has told elaborately about the importance of nutrition and protein administration to a patient with sepsis. So these patients, you try to start feeds as early as possible. As long as gut is functional, try to use the gut. So enteral feeds, oral feeds, if not enteral feeds through Riles tube. And if patient is not tolerating enteral feeds, maybe that also you can give a time of 1 week. Then you think about the parenteral nutrition. So someone coming with pancreatitis, landing in sepsis, septic shock, that kind of patients. So someone with pneumonia, if they are on ventilator, follow the ventilator bundle strictly and try to give the oral hygiene. So whatever components, I think everyone might be knowing. So oral hygiene, frequent suctioning, and look for the readiness of the weaning every day. Sedation holiday, which is more important, and putting the head of the bed elevated so that you can prevent the further aspiration. Microaspiration is the basic reason for VAP. So try to prevent one more infection while treating the primary infection. So because secondary sepsis mortality is very high than the primary sepsis. So someone coming with community acquired sepsis, their outcome will be good. But someone acquiring a sepsis in hospital, usually outcome will be very bad. So to prevent that infection is also a part of your primary sepsis management. So, and at the same time, these patients, sepsis patients, once they enter into the ICU or in hospital, they will be there with us maybe at least 3 to 4 days minimum. So during that period, nutrition, sugar management, ulcer prophylaxis, TVT prophylaxis, and bed sore prevention. If any already bed sore is there, someone coming with coming from the rehab or bedbound patient coming to us, try to prevent the bed sore by putting a nimbus bed or alpha bed, and any pressure sore areas are there, pressure prone areas are there. Those areas has to be addressed. Frequent change of the position of the patient. All these things matter a lot. So it's doctors will just give the orders, but you are the people who are making the patient better. Ultimately, the nursing team will make the patient better, not the doctors. Doctors will give only just orders. That is the basic core idea of the sepsis management. And when someone is having any lines, tubes, daily look and discuss with the doctor whether that line is required for the patient or not. Even if it is a peripheral line. So if someone is having more than one line, you discuss with the doctor, he is having only 1-2 injections. So I think the second line is not required, because anything breach to the natural barrier of immunity, that will give a source of infection. So try to take out the lines and tubes as early as possible and give proper care to the patient. So this is my viewpoint on sepsis management. Dr. Amar, any questions or?
Would like to take a few questions. Be online. We are just.
Good afternoon, sir. Thank you for your review, sir. So here is one question we got from the audience. So if there is an uncontrolled hypovolemia, what is the immediate steps to be taken by the nurse? So if it is uncontrolled hypovolemia.
Uncontrolled hypovolemia. Hypovolemia is nothing but a hypotension. Patient is in hypotension. Then first, as per the guidelines, you have to start the crystalloids. So the preferable crystalloid is initially when someone comes to the hospital or ICU, or when you identify someone is in sepsis with hypotension, NS is the choice. So you try to give 30 ml per kg of NS. Suppose weight of the patient is around 70 kgs, you can give 2 liters of NS over 3 hours time, maximum of 3 hours time, or you can give as early as possible. So while giving, you take, if echo machine is available bedside, try to look into the IVC. So if your IVC is collapsible, further you can give more fluids. So actually there are two concepts in the maintenance fluids: bolus fluids, maintenance fluids. Bolus fluids always recommended in sepsis. Maintenance fluids, there are two schools. So there is no role for maintenance fluids, or if the patient is fluid responsive, then only we will give another bolus fluids. So if the patient is further fluid responsive after giving your initial bolus, looking at the IVC, you can give one more bolus and look for the responsiveness. So while doing that, don't wait for the only fluid to correct your hypotension. You start the noradrenaline simultaneously, because time delayed will be like, it will cause renal injury. So you start the noradrenaline, give fluid, one, and look for the peripheral signs like capillary refill time, lactate level, and again assess the patient again and give one more fluid bolus. So that has to be continued. Hello? I think
organ disorder. So which organ we need to take it as a priority?
Normally, when someone lands up in sepsis, we have natural mechanism that body will take care. Initially, when someone is landing up into the sepsis, so there will be splanchnic vasoconstriction and cutaneous vasoconstriction, so that the whatever peripheral circulation is there, that will be diverted to your core organs, that is brain, heart, and kidneys. So these 3 organs will be taken care initially, and the most sensitive among all these organs is our kidney. So that is the reason, if we don't have any other monitoring tools, we will monitor the urine output. If your urine output is good, then you can assume indirectly that your perfusion is good. So among these 3 organs, I feel kidney should be given most priority. That's it.
Thank you, sir.
Okay.
I think you covered most of the point. Actually, in the presentation also, we divided it into 2 sections. Wanted to cover sepsis topic is a vast subject. So few SOPA criteria we not covered, like quick sequential organ failure assessment score. That we'll cover in some of the other next part 2 septic webinar. And you made today's topic very interesting, and you spoken the way like staff nurses can understand. And hope all audience enjoyed the today's webinar. And please be logged in on Yashoda page, Yashoda Hospital Facebook page. And 12th January, you are getting the final quiz competition webinar is there. Please attend everyone. So thank you one and all. Thank you, Gayatri, for being today's speaker. You given a nice presentation. Thank you, Ojna, and complete digital team for one and all. Thank you.
Thank you.